Yeah, we'll get going as soon as we have a few more people. All right, why don't we get going here? Hope all had a good weekend, and let's see what we got today. All righty, so this is from an EP study, and what we see here is ventricular pacing. And the question I'm posing here is this usual or normal ventricular atrial conduction or not? So why don't we ask Dr. Mukhopadhyay what she thinks?
Good morning.
Katoki, are you there? Toki? Toki, are you there?
Sorry, wait, sorry, yeah,
Sound like you're in a hallway or in a
yeah, sorry,
tunnel. Okay, so that seems like that's not going to work. So why don't we ask Dr. Bezdakova what she thinks? What do you think, Christina?
Morning, Dr. Path. Just looking at this P study, and
So we're V-pacing. Let's just review again. We have 1, 2, 3, 4 electrocardiogram surface ECG leads. In this case, leads 1 AVF, V1 and V6. We have a MAP catheter, which is the ablation catheter, distal and proximal. And the high RA and the His channels seem to have no signal on them. And the coronary sinus pairs are in place, going from CS proximal out to CS distal. And then finally, this is the RV. And this is the stim channel, just telling us that we're pacing. S1, which is just, a drivetrain, basically.
so it looks like the earliest signal is coming from the RV channel.
The earliest what? I'm sorry?
The earliest V.
Yeah, that's true. Well, that's because we're pacing in the V, right?
Yeah, and then looking at the CS catheters, it looks like the earliest signal is, let's say, from CS proximal, which should be normal VA conduction.
Okay, so you're saying that CS proximal is the earliest retrograde A. Am I understanding you correctly?
Yeah.
Okay, so actually, so let's just remind ourselves that these are all the ventricular electrograms, and these are all the atrial electrograms. Okay. So, for example, if this is the atrial electrogram, is this earlier or later than this electrogram?
Oh, so then the distal is earlier than the proximal.
Right. And so this is a very abnormal pattern, right? Because it's sometimes we would call this an eccentric pattern because the earliest retrograde A is in the left lateral, right? CS distal is where relative to the mitral annulus?
It is the most distal from the mitral annulus.
Right. So would that be medial or lateral mitral annulus?
medial.
No, lateral, right? Where is the medial mitral annulus?
By the CS proximal.
Right, and so CS proximal is is near the crux of the heart. So it's sort of in the center of the heart, whereas CS distal is very lateral, right? So anything CS distal is going to be lateral mitral annulus versus the proximal CS. So this is actually, well, that's always the case. Now, it could be that people display it differently. Sometimes some electrophysiologists will display the distal on the top and go more proximally. And one of the sort of confusing aspects that both Barry and I do is that we go distal proximal, distal to proximal on the Hess, but then in the CS we go from proximal to distal, which is a little confusing, I know, but this is just sort of more a habit than anything else. But so the bottom line is now, so if you were going to say, where is the pathway? Is it which coronary sinus pair do you think it's closest to? Can you guess based on this?
And the CS distal.
Right. So it's either CS distal or 3-4. So you get 100% credit for either of these. But right there, if you imagine that the A is starting here, I think if we were to place a caliper line down here, this might be maybe 2 milliseconds earlier than the CS distal. Why is that important? It's important because when we're mapping and we're moving the ablation catheter, sometimes what we'll say when we see it look like this is that the pathway is bracketed. And when we say it's bracketed, what we mean is that there is a coronary sinus electrode that is distal to the pathway and a coronary sinus electrode that is proximal to the pathway. And the reason that this is useful is because it means that because this electrogram, this atrial electrogram, is a little bit earlier than this distal electrogram, it means that the likelihood is very high that the pathway is not distal to the coronary sinus distal pair. So when you're mapping, you know that although you might want to move the catheter transiently distal to the distal CS to confirm that, this pattern suggests that probably the pathway is on the medial side of CS distal. Sorry about that. Is on the medial side of CS distal because the pair that is slightly medial to the distalmost CS pair is slightly earlier. And the pair that is, and if we go to 5-6, I think we would agree that this pair is clearly later than either 3-4 or distal. So we know, therefore, that the pathway is somewhere between CS distal and CS 3-4. And that's exactly where the pathway was mapped to. If you look in the distal ablation catheter, you can see that this is not a good signal because we like to see an A and a B that are of similar size when we're on the annulus. But this it's actually, this is a bad example, so let's just not even talk about that for right now. But the point I'm trying to make here is simply that this is what we would call an eccentric pattern. Now, if this was going up the AV node, then the earliest A would be in CS proximal, as you said, but all of these A's would be later, so that as we move farther and farther from the crux of the heart, the A's are getting later. And the reason for that, of course, is that it's going up the AV node, and then it is passively depolarizing the left atrium from the AV node if there were no pathway. Okay. Any questions about that? All right. So now in this tracing, I'm going to ask, since Dr. Kalis is here, is the pathway ablated?
Morning, Dr. Pass.
Lamar?
So now it's like we are pacing in the V, and now I'm seeing the earliest A is in CS proximal.
Okay, now, let me ask you this. Is there an A after every V in this tracing?
There's only an A after, it's like 2 to 1.
Right. Okay. And so let me just remind you, this is what the patient looked like before. This is the patient now. So I agree. It looks like there's 2 to 1. So just for everybody, here we have a V with no A. There's a V and an a V, no a V and an a V, no A. So the question then is, do you think the pathway is gone? I mean, we are seeing some conduction. Is this 2 to 1 through the pathway, or what? What do you think?
Well, I don't think it's 2 to 1 through the pathway.
How do you say that?
Because the pattern looks different in terms of
That's
where
right. Which is the earliest day now?
now the earliest A is CS proximal.
Yeah, right. Exactly. So this is the earliest day, and we see that's, very subtly as we go more and more lateral, these A's seem to be a little bit later and later. Now, the interesting thing is this A looks maybe even a little earlier than here, but sometimes when we put the coronary sinus very far out on the annulus, it can wrap around towards the anterior portion of the annulus and actually start getting earlier again. But the point is, I think pretty clearly, CS Prox is a little bit earlier than the others. Okay. So what do you think? Is the pathway gone?
Well, I mean, it looks like we're not conducting through the pathway. I don't know if it's gone, but I think it
Okay. That's
seems
true. We never do know when we're in an ablation if the pathway is definitively gone. That's a deep point. But is it at least transiently blocked at this point?
yes, I think
Yes.
transiently.
Yes, it's at minimally right. So some of you may read, as you know, after every case, I will send the fellow the cath report that I write. And I'm just going to mute you there for a second, Maya, just because I'm hearing myself as back. But some of you see, if you read the report, I always write in the conclusion, acutely successful ablation. Um, but I never actually, I never say successful ablation without the word acutely because we never really know. One of the things people don't really understand about ablation, at least patients don't, is that we don't actually, right? You've all been in ablations now. We don't actually see the pathway. We infer where the pathway is based on the electrical signal, but we don't actually know if we could have injured the pathway without permanently causing blockage in the pathway. And this is one of the reasons why we wait usually 20 to 30 minutes after ablation. Some electrophysiologists will wait an hour. And also the reason why we never declare victory. When I come out, I always tell patients that there is a small chance that the pathway can recur. And the general rule of thumb with radiofrequency ablation is that if in 3 months it does not recur, usually it's rare for a pathway to come back after that point. Now with cryoablation, I've seen pathways come back 6 or 9 months after ablation, so I don't trust cryo quite as much. But so we would say this was an acute success. And see now, it happens that so Maya, our left-sided pathways more, if you were like advising a parent, and you did, let's say it's a WPW patient and you could tell that it's a left-sided pathway, do you think that the chances of success are higher or lower if it's a left-sided pathway?
I don't know for sure, but I would think that it's probably higher chance of success with the left-sided pathway.
Why do you think that would be?
Just thinking that it's further away from the AV node, so it might be, we might be able to be a bit more aggressive with ablating it.
That's a good point. I never really thought of that, but that's true. We certainly don't have to worry as much about heart block. That's true. And in fact, you can see that this operator, who happens to be me, didn't even have a His or an RA catheter in place because the pathway was so far from the His that some of you know that I will sometimes do left-sided pathways with a so-called three-catheter approach. But what are some other reasons do you think that it might be more successful? If it's on the left side versus the right side. Like, I will tell you that you're right, that when I'm about to do a right-sided pathway, I am always more nervous about that case than left-sided. Why do you think that
I
is?
guess since you have, like, through the coronary sinus, it's perhaps easier to kind of access those areas.
Well, I mean, on the coronary sinus, I don't actually I don't burn usually through the coronary sinus, but the coronary sinus is part of the answer, right? Like you have seen, I think maybe it was either Christina or Vlad was in a case with me recently where we ablated somebody just inside the mouth of the coronary sinus. But as a general rule, we don't like to ablate inside the coronary sinus. Why do you think that is? Let me ask Mohammed. Mohammed, why do we not like to ablate inside the coronary sinus, right? Because in theory, with this pathway, right, when it was, let me just go back a slide. Right, I could have slipped the catheter into the coronary sinus and got it near CS3-4 and ablated it. That might have actually worked. Why do we go to the trouble of a transeptal puncture and going into the left side to the mitral sinus? Why do we not like to burn inside the coronary sinus if we don't have to?
Good morning, Dr. Paz.
Yeah.
I'm not entirely sure, but I think maybe it's like a more injurious when you do it inside the coronary sinus.
Well, it is more injurious. So does anybody know the answer to this question? I've gone over it once or twice, but maybe not in a recent past. So, how does radiofrequency ablation work? So some of you see that when I do cases, I use the most standard catheter, which is what's called a temperature-controlled ablation catheter. And essentially, the way that the system works is you tell the system, I want to reach a certain temperature. In this case, the temperature usually is either 65 or 70 degrees Celsius. That's pretty much a standard RF temperature. The catheter has a closed loop and essentially will raise the power needed to achieve what that temperature is. So in the heart, like let's say we're on the mitral annulus, the entire cardiac output is passing the mitral annulus when you're doing the ablation, right? And so the tip of the catheter is constantly being cooled by the flow of blood across the tip of the ablation catheter. And so when you tell the system, I want to hit 70 degrees Celsius, it jacks up the power to achieve a goal of 70 degrees Celsius. And some of you may notice that we basically never achieve 70 degrees Celsius. And the reason for that is because there is so much blood flow cooling the catheter. So it's not uncommon that when we ablate somebody, let's say on the left side of the heart or the right side, that the power will be 50 watts, which is the maximum output of the system. And you only achieve a temperature of maybe 42 to 46 degrees Celsius. That is generally considered to be a good combination of both power and temperature to achieve a good goal of blocking a pathway. But when you are in the coronary sinus, there's very little blood flow. All you're seeing really is the venous return of the coronary arteries. And so there is very, very little cooling of the catheter when you're in the coronary sinus. So if you have a catheter in the coronary sinus and you have a very good signal, if you turn on RF, if you set the system for 50 watts and you turn on RF, set it for a maximum of 50 watts and a temperature of, say, 70 degrees, what happens is it hits 70 degrees with almost no power at all because there's nothing cooling the tip of the catheter. So you can set it at 70 degrees, and basically at 2 watts of power, it'll achieve 70 degrees because nothing is actually cooling it. And in order to make a lesion, bench testing has shown that you need both a delivery of power as well as temperature to make a lesion. And so in the coronary sinus, one of the reasons we don't like to burn there is because it's very difficult to achieve a good lesion because you don't have enough cooling to allow for enough power delivery. On the other side, if you do achieve, the other problem in the coronary sinus is it's a vein, and you can perforate the heart back there, and you can bleed out. And so one wants to be very careful about burning in there. Sometimes we'll use an irrigated catheter, which is the catheter that Barry uses more typically for all his ablations. And the benefit of the irrigation is, in those cases, those are power-controlled catheters. And so the catheter is providing the cooling at the tip of the catheter, so you don't actually need blood flow to make a lesion. And so typically, if one's going to burn inside the coronary sinus, which again is something you want to be very, very cautious about, one would use very low power with irrigation in order to achieve a lesion there. So that's the reason we don't typically burn inside the coronary sinus, and why we would rather, if we can, if there's any way to get a pathway that does not involve going in the CS, that would be the preference. Sometimes it's the only way. Sometimes pathways are right inside the mouth of the coronary sinus, in which case it is safer and easier to do it that way. But even then, one needs to be very careful about too much and having a perforation, which can be a very serious problem. Okay, let's move forward. Any questions about that?
Can I ask why it's only showing VA like every other? Like I know Maya mentioned it's not in the pathway of what the accessory pathway was, but why we're seeing like intermittent VA?
That's a good question. So what happens if I were to pace your heart, Molly, at like 150 beats per minute? What would the conduction look like?
If you're V pacing me?
Now, let's say I'm A pacing you.
If you're A pacing me, then I'm assuming sorry?
Yeah, I'm pacing, let's say, at 150 beats per minute. What would happen? Would you have a V rate at 150 beats per minute also?
Yes, I would assume I would.
Yes, you're a healthy person. I would expect that also. What happens when I get to 175, do you think?
Based on how my heart rate looks when I run, I also assume that I would.
Right, you probably go up to 175. Now, what if I went up to about 200? What do you think would happen?
Probably not. Like, there'd be times where I don't think I would.
Right. What would happen? What would we see on the ECG? Let's say I'm running an ECG on you, and you've been kind enough to allow us to put a catheter in you as a science experiment with all your fellows at the bedside, and I'm now pacing you at 200 beats per minute. What would the ECG show? I agree. You probably wouldn't go 1-to-1. What would we see? Probably.
Like Winky Bach?
Yeah, you probably would see Wanky Bach. Maybe you'd be going like 3-2, right? Or something like that. And then what if I went to like 250? What do you think would happen?
We eventually would get to like 2-to-1.
Right. You'd probably go to about 2-to-1, right? Because first of all, if you're lying on the table, it's not the same as if you're running, right? Where your adrenergic tone is high. In other words, if I put a catheter in you and I got you on the treadmill and I had you running for like 15 minutes, and then I tried to pace you, it's possible you might conduct 1-to-1 at 250. You're a young, healthy adult, but probably you would be wanky bocking at about 250, and maybe at 275, you'd be going 2-to-1. So just like that happens antegrade in the AV node, it can happen retrograde in the AV node.
Okay.
And the interesting thing is that most adults do not have ventriculoatrial conduction. And so, one of the things that we do when we're, I'm sure you all have seen that when we have an accessory pathway, we will often do V pacing and give adenosine. And the purpose of that is to confirm that there is no ventriculoatrial block in the setting of an accessory pathway. And why do we do that, Molly? Why do we do that, and why do we do that after the ablation?
Why do we give it? Sorry,
What does the adenosine post ablation help us understand? Why do we do that?
you're showing. Mm,
Yes. So accessory pathways, are they adenosine sensitive or insensitive?
they're insensitive.
They're
Typically.
insensitive, right? So if I gave the adenosine at this point in the case,
Mm-hmm.
expect that this pattern
still
will
see it.
persist the entire
Mhm.
time, right?
Oh, so because you're trying to mask if you're giving it after, you're masking or you're wanting to
Mm-hmm.
block adenosine sensitive, which is typically not your pathway. So if you still had the pathway, you would see it.
Right,
You do
right.
it. Oh, yeah.
Right. So one of the reasons we do it is because we don't know, as long as there's a pathway present, we don't know what the patient's retrograde AV nodal conduction is.
Mm-hmm.
Okay. So some patients have no AV nodal retrograde conduction. Like I would get, I'm gonna make this number up, but I bet I'm not wrong. If you took like all 18-year-olds that we ablate, probably 40% of them have no VA conduction at all, except at maybe very, very, very slow rates. So in some patients, you ablate the pathway and there's actually no ventricular atrial conduction. In those patients, you don't have to give adenosine after the ablation because you don't have any VA conduction at all. Now, some people would give it because the theory is that maybe you would fully block the node and you'd see the pathway. But the truth is if you have no VA conduction through the AV node, then that should maximally show you if there's any residual pathway left, right? But in some cases, there is still VA conduction, particularly in little children or anyone under like 10 or 12. They often have VA conduction even in the absence of the pathway because their node is still robust retrograde. And so even though the pattern, right? If we saw this pattern here on every beat 1-to-1, I think we would all agree that this pattern is clearly very, very different than this pattern when the pathway is still there. But this would be a case where if this was going 1-to-1 on every beat, I would probably give adenosine after the ablation in order to block the AV node and make sure that there's no indolent or mild pathway conduction. And the reason for that is obviously you'd want to know that while the catheters are still in the heart, because you still have an opportunity to ablate the patient while you're still in the lab. So we always want to, in a perfect world, we would stay there for 2 hours after an ablation and just keep testing and testing. But there's concerns about that also, right? Especially in a left-sided ablation. Do we really want to keep a catheter in the left atrium an extra hour? That's not necessary in terms of risk for thrombus and stroke and things of this nature. So it's always a balance when we're deciding what to do in terms of post-ablation testing. But the point I'm trying to make is that's the reason. So in reference to your question, this is just retrograde 2-to-1 conduction through a patient whose AV node retrograde isn't so great. And if I were pacing even a little bit faster, in fact, I did in this patient, there was no VA conduction rates of this is a very slow pacing. I think this was at a rate of about 100, and at about 115, 120, there was no VA conduction at all.
Got it.
So,
and then, sorry, just to follow up on what you're asking, Maya, is the left-sided pathway just better because you're able to map better in terms of?
Yeah, you know what? Thank you for bringing that up. I never fully answered that question. Okay, so a couple of things. First of all, as Maya suggested, we can be more aggressive. And so certainly although there's no evidence for this, it certainly makes sense that if you burn more times around something, probably on average, you'll be more successful. Second, there's one major difference between left-sided pathways and right-sided pathways, and that is the coronary sinus. And so the coronary sinus allows us to put a catheter around the mitral annulus, which gives us such a beautiful understanding of where the pathway is, right? Because there's a coronary sinus catheter in this case, I know that the pathway has to be somewhere near CS3, 4, and CS distal. that's a wonderful gift because it basically means that once I'm in the left atrium, I can push the catheter directly at this area, and I know I'm going to be very close to the pathway. There is no analogous structure on the right side. If you have a right lateral or posterior pathway, there is no analogous catheter position for anything beyond the septum on the right side. So by definition, you sort of have to map everywhere on the right side until you find the right place to put the catheter. And so you really have to map the entire annulus, whereas on the left side, the coronary sinus, because it extends, around about 2/3 of the annular size, or the annulus, it's wonderful. It's as Dr. Walsh used to say, it's God's gift to the electrophysiologist because it allows you to really precisely put the catheter, tell you where you're going to be, whereas on the right side, we don't have that. And finally, I think the other reason that there's two other reasons I think left sides are more successful. The next one is more pathways in children are on the left side than the right side. So I think that all pediatric electrophysiologists are a little more experienced at doing it, and anything you do more of, you're going to be better at. And so left-sided pathways, I think, benefit from that. And then finally, I think that because we do them transeptally, the ablation sheath or catheter is much more stable because the septum is kind of stabilizing the back of the catheter, and it allows you to move more precisely. Now, there are people who do left-sided pathways retrograde, where they go across the aortic valve and then retroflex the catheter back up across the annulus, and they'll tell you that they're very easily able to manipulate the catheter, very carefully around the annulus in a similar fashion, and the evidence suggests that that is true. But I think that in the present era, I'd say most electrophysiologists do left-sided pathways transeptally. And I do think that having either, it's interesting, at Texas Children's, the standard is that you get into the left atrium and then you pull the sheath back into the right atrium and only manipulate the catheter in the left atrium. I assume that's because they're afraid of thrombus, and also because there may be a belief that it allows you to manipulate the catheter a little more freely without having the long sheath there. Other people like myself, Barry, and I think most others like to have the sheath there because we think it creates a little bit more buttressing or support. Barry also uses the deflectable sheath, the Agilis sheath, which he uses as the deflector. He doesn't actually use the deflection of the catheter. He uses the sheath to deflect the catheter. And he likes that sheath because it's a very, very stiff sheath. So once you're in proper position, the chances of the catheter moving are much less. The reason I don't care for that catheter all the time is just mostly because it's very large. It's like the outer diameter is like 12 French. So if I don't have to put in such a large sheath, I'd rather not. But it's perfectly reasonable, and lots of people like to use that sheath or sheaths like it. So those are the reasons why left-sided pathways in general are easier to ablate. Downside, of course, is you have to do transeptal. So transeptal carries its own risks, obviously, but assuming that you know how to do a transeptal and that it goes smoothly, then in general, electrophysiologists would prefer to see a left-sided pathway. Okay, any other questions about this? All right, I think if that's the case, we'll stop, and welcome back. Hope you all had a lovely Thanksgiving. And I'll remind everybody that we have our holiday party on Friday. I hope everybody's able to make it. And I'll see you in Sinai in just a little bit.
Thank you.
Thank you, Doctor.
Thank you.
Bye-bye.